Everyone, and welcome. I'm Scotty Sims, founder and CEO of KCNQ2-Alliance, and we're glad you're here to join us tonight. Thank you for spending part of your evening with us. Tonight is the first webinar in a two-part series on genetic medicines for KCNQ2-related disorders. Genetic medicine is one of the most exciting and rapidly evolving areas of research, and we know many families have questions about these emerging approaches that's being explored for KCNQ2 and what all of this could mean for us in the future. In part one, we'll focus on antisense oligonucleotides, or ASOs. We'll cover what they are, how they work, and what is being studied for KCNQ2 related disorders and where the research stands today. Then in part two, we'll expand the conversation to explore gene therapies, including approaches like gene replacement, gene editing, and other emerging technologies. Our goal throughout this series is to make these complex topics as understandable as possible while providing an accurate picture of where the science stands today. Before we get started, just a few quick housekeeping notes. As questions come to mind during the presentation, we encourage you to submit them using the Q&A feature at the bottom of your Zoom window rather than the chat. Using the Q&A box helps us keep everything organized and make sure that we don't miss any questions during our discussions. If you prefer to ask your question live, you can use the raise your hand feature during the Q&A and we'll invite you to unmute when it's your turn. At this time, we're preferring to use the Q&A option if possible. We're recording tonight's webinar and we'll post it on our YouTube channel afterwards so you can watch it again or share it with others who weren't able to join us live. All right, our first speaker this evening is Brooke Babineau, Scientific Director of KCNQ2-Alliance. Brooke is also Associate Director of In Vivo Pharmacology at Sonother, where she leads drug development initiatives focused on rare diseases. She's dedicated the bulk of her career to understanding the research between brain behavior and advancing therapies for children with neurodevelopmental disorders. Tonight, Brooke will walk us through the basics of genetic medicine, explaining the different approaches researchers are exploring, discuss each strategy as are currently being investigated for KCNQ2-related disorders, and help us understand why some approaches may be more or less promising based on the biology of KCNQ2. She will present an introduction to antisense oligonucleotides, also called ASOs. She'll explain what ASOs are and how they work, why they're considered a promising approach for some genetic disorders, and what researchers have learned so far about their potential in KCNQ2-related disorders. She'll also help put this research in context and lay the foundation for a second webinar where we'll explore gene therapy approaches in greater depth. Brooke, thanks so much for being here. I'll hand it off to you.
Absolutely. Everyone can hear me okay? Scotty, give me a thumbs up. Michelle's nodding. All right, sounds great. Well, thank you all so much for being here. I was scanning the panelist names, and it's great to see some names I recognize from the Facebook group. Some of you have reached out to me over email. I do just want to say, like, I'm here for you all. I'm glad you are here today to go through this together. And please feel free to enter questions in the Q&A at any time. As Scotty alluded to, this is a very complex topic. I do this as a full-time job and have about 20 years of academic investment in it, and it is still hard to understand. So please, please, please ask your questions. Again, we are doing this so that we all as a community understand where we are, where we're going, and how we get there together. So this is part one today. We're going to talk about ASOs, kind of building on a recent webinar from Boston Children's Hospital. If you haven't seen that one yet, I do encourage you to go back and look at that. You can find it on our YouTube channel. And this is just our way to have a really focused conversation on the KCNQ2 genetic medicine space. Okay. So today, what we're going to try and overview, and I'll try and work my way through quickly but clearly a number of parts before we get to hear from Kara, who's going to talk through her experience with ASO development on a personal level. We're going to review the gene to protein pathway. What's the difference between DNA and RNA? Why does it matter when thinking about genetic medicine? Then we're going to dig down on antisense oligonucleotides, which is the one and only time I'll say that, and we're going to just call it ASOs from here on out. And we're going to talk about why not only the genetic change in your DNA matters, but the functional effect of that change in DNA matters when you're thinking about therapeutic approaches. You're going to hear some words like haploinsufficiency, dominant negative, gain of function. Some may be familiar, some may not. That's okay. We're going to do our best to explain them and why it matters when we're talking about therapeutic strategies. And then, as I mentioned, Kara will share her experience once I get through those topics. Okay, so the gene to protein pathway, and again, some of you may be familiar, some of you might even seen slides like this that we've presented before, but we're gonna just take a quick turn through this. DNA, the DNA we're talking about is the KCNQ2 gene. DNA is sometimes referred to like the family cookbook. This is where you want to go to if a specific dish is needed. You're looking at that individual part of the cookbook, the KCNQ2 gene. That gene then goes. We think about the gene then creating this RNA. This is what's going to tell the body how to make a protein, and that protein being the completed dish. And so the RNA may be your handwritten copy, the notes you make, and sort of exactly what you want as your outcome. And so that RNA then becomes your completed dish, your protein, which is the functional piece that works in our body, right? So that KCNQ2 gene has this intermittent step of turning into RNA. And that RNA goes through some machinery in our body that creates the protein. That protein, and we'll show you and we'll talk about how that protein is really our channel, the KV7 channel. And that's what's going to create this, all the sort of functional pieces, the consequences that are exhibited as the symptoms that individuals experience from KCNQ2 mutations. And again, please feel free to write in questions if anything on here is not clear. So the idea of genetic medicines is that they act on these early parts of the pathway. They can act directly on the gene, or in the case of ASOs, act on the RNA, this intermediate step, to target the cause of the genetic disorder. And so they can, through interacting with the DNA or the RNA, they can impact the protein that is meant to come from those products, and in that way we are addressing the source of the functional changes that lead to the symptoms. Okay, and so then if we think about how genetic medicines can target either DNA or RNA, DNA targeted medicines are going to actually go in and change the original recipe. So it goes straight to the DNA. Maybe it's adding a word in the cookbook that wasn't there. Maybe it's switching a couple letters around that were, mistakenly mixed up. But it's actually going into the source material and changing the information there. These RNA-targeted medicines change that handwritten copy, right? So now you've sort of taken from that family cookbook, you've got that specific set of information on your KCNQ2 transcript. You can go in and your RNA-targeted medicines are going to maybe fix those handwritten notes, and maybe instead of actually making that protein that we don't want to make, we stop making it. There's ways that these RNA-targeted therapeutics can also increase the amount of protein if the problem was that you actually didn't have enough. So the RNA-targeted medicines are still very specific. They are targeted to the root cause of disease, but they are focused on a different part of the pathway. To expand on that a little bit more, What ASOs actually are just small synthetic pieces of RNA that can bind to the RNA in our body and either boost, increase, or suppress the production of a specific protein. So again, all of these therapies are really interacting in the pathway that leads to protein, and the functional consequence is either more or less, or in some cases, different protein. And so the effects of ASOs are relatively transient. So often with ASOs, you're going to need, or always with ASOs at this point, you're going to need to come in and treat intermittently. So for many ASOs right now, it's about on the order of a couple months. So it's not a daily therapy like some of these small molecule medicines you take, right? Your anti-seizure medicines, things like that. Those might be daily or even more. Those kinetics are very transient, right? Those act very quickly and then they're out of the system. ASOs have a transientness, but it's slightly longer than some of the anti-seizure medicines. So you're looking at more of like a 3 month timeline. Right now, for neurological disease, these are administered via a lumbar puncture, or also called an intrathecal injection. And so it's not the most ideal way to deliver a medication, but this is how it gets into the cerebral spinal fluid, which is its sort of direct path to get into the brain. We could have a whole conversation about blood-brain barrier and why that's a pain in the butt, but that's for another day. And so ASOs, again, like ASO as a class, as an overview, just these small synthetic pieces of RNA. And so different ASOs, meaning ASOs that have this synthetic sequence or ASOs that have that synthetic sequence, they're built to work in different ways so that functional effect of the genetic variant we're trying to treat is really going to lead to what type of ASO used, right? So if the outcome we're looking for is to increase something, we're going to need an ASO that does something different than if we're looking for an ASO that we want to downregulate something. Also, ASOs are specific to the gene or the disease. So an ASO that works in Dravet syndrome is targeted to the SCN1A gene, not the KCNQ2 gene. And so ASOs by nature are quite specific, both in their target and then how they work. Okay. So we're going to get into variant type versus the functional variant effect. Again, I know these are conversations we've had in different spaces, and the functional variant effect is important for a lot of reasons, and one of them is its relationship to genetic medicine. So the variant type, this is information that you might have gotten on your genetic report. This describes what happened to your DNA sequence, what happened in that source material, that family cookbook. Was there a missense mutation, meaning just some of the letters got scrambled and now that protein you make has a slightly different outcome than what it was originally meant to look like? There's things that just sort of create a lack of the protein. These could be a nonsense mutation, a deletion, or ways in which the recipe essentially leads to something that is not produced, right? So the recipe kind of cuts off, or it becomes so jumbled that it doesn't make a product at the end. And so what the consequence of any of these is relates to that functional variant effect. So a missense mutation can lead to a protein that causes our channel not to work as well. That's what we call loss of function, right? So our variant is how that cookbook is changed, our variant type. The functional variant effect is how that protein or that finished dish actually acts in the cell. And so the different words we use here, again, would be something like a loss of function, where that protein product isn't working as well. You could have something called haploinsufficiency, where you're getting a reduced amount of the protein. That can cause a loss of function. A dominant negative mutation can also lead to a loss of function. And we'll talk a little bit more through each of these as we move forward. The flip side of a loss of function is a gain of function. And so now you have a protein and it's doing its job, but it's actually doing it too well. And especially in the brain, that happens to not be so good. In the brain, we talk about a lot about these Goldilocks zones. Everything needs to be just right. So when something's working too well, that's not great either. And sometimes it's just not clear. We don't have a clear loss of function or gain of function, and you might hear something about mixed functional effect. So again, there's separate pieces of information. There's the variant type, how your DNA has changed, and then what that effect is functionally. Michelle has put in a good example here. So if your variant type is a missense. The word salt was misprinted as sugar in the family cookbook. And the functional effect of that is the dishes produced from this recipe turn out too sweet. I had the opposite consequence one time. My friend put salt in the snickerdoodle recipe, and those cookies were really not edible. So, but that's how we're thinking about this. The variant type, something changed, and then it has this functional consequence. Okay. All right. So why does this matter when we talk about genetic medicine? And again, I recognize all of this can seem like a lot, but I'm around. I'm not going anywhere. We'll have questions and answers time today, and you all know how to get a hold of me on Facebook or email as well. So I'm happy to take questions after this. This webinar is complete. So getting back to genetics, every person has 2 copies of the KCNQ2 gene, one from each parent. So we've represented that here, 1 copy here, 1 copy here. Both are used to produce a protein called KV7.2. And so here's our gene, here's our protein. Here's where we up the ante a little bit. We're going to talk about how those proteins become a channel. And so the potassium channel we're talking about, the KV7.2 channel, can sometimes be 4 subunits of KV7.2. It can sometimes be 4 subunits, 2 of which are KV7.2 and 2 of which are KV7.3. That's often why mutations in KV7.3 can look a little bit like KCNQ2-related disorders. You don't really have to worry too much about this, but these are just sort of fun words you can impress your friends with. And so these are potassium channels. Potassiums are little K here. They're positively charged ions, potassium ions. So the potassium channels are responsible for letting potassium ions flow out. And this helps kind of cool off the neuron, calm down the neuron, because if too many potassium ions are inside the cell, that's when the cell gets excited, and that's when it can lead to hyperactivity, also known as seizures. Some of you may be familiar with sodium channel blockers. Sodium channels allow positive sodium ions in. And so one way to deal with the fact that not enough potassium channels go out in KCNQ2 related disorders is to sort of prevent too many sodium channels going in. Just wanted to touch on that while we were here. Okay. Most individuals with KCNQ2 related disorders have a change in just one of their genes, right? So 1 copy here intact, giving the KV7.2 channel that was intended. But if there is a mutation in this gene, one of a few different things can happen. Again, if there is a deletion, you might just not make the protein. This might lead to a loss of function, or also called haploinsufficiency. Less protein is around. You could get a dominant negative situation, which we'll talk more about, which can also lead to loss of function, or that change might lead to a protein that creates a gain of function, functional effect. So the ASO strategy taken will depend on how this genetic change impacts the protein. Okay. For the KCNQ2 gene, and this is specific to the KCNQ2 gene, it's not always the case. Haploinsufficiency is known to lead more commonly to the self-limiting neonatal epilepsy, meaning those seizures happen early on, but developmentally, many individuals find themselves following a sort of typically developing track. It is the mutations that result in more of these dominant negative loss of function or gain of function that lead to the developmental and epileptic encephalopathies, or the DEEs. And like I said, this is not always the case. In Dravet syndrome, this haploinsufficiency is actually what causes the disease. So a loss of one copy of SCN1A leads to all the symptoms that are known to be Dravet syndrome. And so their approach to genetic medicine is very different from ours, given that we know that one copy of KCNQ2 can actually be fairly sustainable, so to speak. So just digging down quickly on haploinsufficiency, again, haplo meaning half, and insufficient, not enough. So haploinsufficiency means half as much as needed. And so you can kind of visualize it like this. One copy of KCNQ2 doesn't produce a working protein at all. And so all the KV7 proteins produced are functional. There are just not as many as you would typically have. Looking at that in sort of this diagram mode, instead of like the 3 sets of channels we had before, that might be reduced to 2. So yes, less potassium flows out, and you might have a buildup of potassium inside. That is likely what's leading to those seizures early in life. But I think by and large, there's compensation that the brain can do to sort of overcome this scenario, such that again, by and large, those individuals with these types of mutations will have typical development. Okay. This is as compared to what is, I think more commonly seen in our community, and especially for those whose family individuals experience the DEE type symptoms, is this dominant negative situation. So now the mutation or the change in the KCNQ2 gene leads to a protein being made, but that protein actually interferes with the way that the channels are working. So it's not an issue of the amount of protein produced, it's the activity of the variant protein. So what that looks like in this diagram is, again, you kind of go back to the beginning. You have these 3 channels, but 2 of these channels have a mutated copy of the KV7.2 subunit. And so the potassium can't flow through those, and you have an even more severe buildup of these potassium channels, and it makes it harder for the brain to compensate. Yeah, Michelle's going to answer the question that just came up in the Q&A. Great. And so this is what this sort of backup of the potassium channels is essentially the root cause of the developmental and neurological symptoms, even beyond those early seizures. Okay. So how do we treat loss of function? That's sort of where we were getting to today. And I want to make sure we have plenty of time for Kara, so I'll try and be quick through some of these. The therapeutic approach for us, again, specific to KCNQ2, knowing that we sort of have a sustainable state if we just have one working copy, is essentially to turn off the mutation, the copy with the mutation, such that we turn the scenario into a haploinsufficiency condition. And this can be done with something called an allele selective knockdown with an ASO, right? Because we don't want to turn off this copy. We do want to turn off this copy. And so essentially we need to figure out ways in which to differentiate this copy from this copy. And so again, Kara will take you through her journey with NLORM today. And so NLORM is an organization that takes individuals essentially one at a time, making personalized medicine. And they use this antisense oligonucleotide approach so they need to have conditions in which an ASO is going to be effective, meaning that, typically that knocking down something or reducing something is going to be the therapeutic approach. So KCNQ2 is viable for this because of the fact you can knock down the copy of the gene with the mutation. And so their approach is to not target the variant or the mutation itself, but to find a marker nearby that is unique to this copy. It doesn't show up on that copy, and then the drug is designed to interact only with the impacted copy, such that it turns off or at least greatly reduces that protein that was getting in the way. Again, at our last webinar, if you were there, and if not, it's on YouTube. This is very similar to the knockdown approach that the Boston Children's Hospital group came and talked to us about. For them, they're actually looking for markers that might be shared across the community. That's an important piece of their development. But the basics of the ASO approach are very similar, if not identical, to NLORM. They're looking at an allele selective, finding ways to knock down only the copy with the mutation. Okay. We just sort of talked about like a dominant negative scenario that was loss of function, but this, in gain of function, you can think about it actually very similarly at the level of the DNA change and the impact to the protein. You're creating a DNA change that leads to the production of a protein, but this protein doesn't work the way it was intended. Again, you're not producing more KV7 than typical, but you're producing a copy of the KV7.2 subunit that works too well. So our diagram one more time. Now, when you have this gain of function protein in your channels, instead of not enough potassium going out, you get too much potassium going out. And while this leading to seizures might not make as much sense because the positive ions are actually going out of the cell, the brain's just funny like that. It likes things just as it is. And so, we get a set of symptoms that are very similar, even when the channel is sort of having the opposite effect. But again, if this is, if you're thinking about the consequence of, this mutation causing a protein that's impacting the way the channel works, an allele selective approach can work here just the same. So if we can find something specific about this copy that has the mutation, an ASO could work here as well. Okay, so this is my last slide, and I'll turn it over to Kara. So ASOs are a type of genetic medicine that target the RNA to influence how genes are expressed. The type of ASO used is going to depend on the functional consequences of your genetic variant, in the case of KCNQ2. Variants with dominant negative effects will need an allele-specific approach, but that approach could also likely work in the case of a gain of function, again, if we're looking to just turn off one copy of the gene. NLORM is a nonprofit organization that's working to develop allele-specific knockdown ASOs across diseases, and happens to be working on it for actually multiple individuals in our community, one of which is furthest along, which is an ASO for Nolan. And Kara's going to talk about that. And the reason we're kind of bringing this to you as well is because you can sign up as an individual. You do need to get the weigh-in of and the buy-in of physicians, and Kara will talk through that process, but we wanted to make sure everyone was aware what that looked like, and how to get involved. And then, as we talked about last month, Boston Children's Hospital is also working to identify targets that would work for multiple different variants. So I will turn it back to Scotty, who's going to set up Kara, and I will also start looking at the Q&A, and we'll see if we can get a few of those answered there.
Thanks, Brooke. That
Yeah.
was fantastic overview. It's always nice to have it broken down and make it more digestible. Next, we're going to hear from Kara Bolter, supermom to KCNQ2 warrior Nolan, and an amazing advocate for our community. Kara's going to share her family's experience with N-Lorem and discuss individualized antisense medicines to the nano rare patients. Kara, thanks for being here. You know, I think you're a rock star. So I appreciate you taking the time to share your family story.
Thank you, Scotty, and thank you, Brooke, for wonderful presentation. So, as Scotty said, my name is Kara Bolter, better known as Nolan's mom. I applied to N-Lorem in October of 2020. We were one of the first, I believe, like 16 patients accepted. And Nolan's program took a little bit longer because of the ally selectivity issue that Brooke has that illustrated in her presentation. So Nolan has a dominant negative loss of function, meaning his bad copy is so bad it brings down his good too. So next slide, Scotty.
Brooke, I think you're in charge of the slides.
Oh, there we go. That's Nolan. Many of you on this webinar right now have probably seen him. Very proud mama. And here's the next slide's good. Here's the overall view of it. If you do get accepted, you do have to have your, which I'll address later on as well, your whole genome sequencing in patient cells. And then the ASO discovery begins. And at the same time, you'll see they do numerous things at the same time to try to optimize as much as they can. It is a nonprofit, so a lot is according to funding. But and according to everyone's individual program. Next slide. So how do you qualify? To qualify for treatment, you need to have a diagnosis, which I assume almost everybody on this call right now has one. And genetic cause must be defined, and the type of change in genetic function must be understood. That is very specifically loss of function, dominant loss of function, or gain of function. And Lorem said anyone who is interested in learning more about their child's particular mutation, they always refer them to these networks that I've pulled off their website. I've never personally referred to them, but I figured I'd include it just in case anyone was interested. Next slide. This is a big part. The patient must be cared for by an investigator-related institution experienced with managing research IND. So a bigger research institution. And if anyone is in the New York area or would find it feasible for them to travel to the New York area and interested in connecting with a team that is willing to take on more KCNQ2 patients, feel free to DM me and reach out to me at any time. Unfortunately, at this time, we are, N-Lorem is mainly treating US patients, and the patients have to be nano rare. So you say, oh, there's more than 30 patients with KCNQ2. So what nano rare is for us is your child's mutation. Like to date, there's not 30 people with Nolan's mutation. So they accepted us again in 2020. Next slide. If you're like, I don't know if I want to qualify, but I don't want to go through all the work, because it is with finding a doctor and a team that is willing to go through the elaborate application process can be tiresome. There is a pre-application review process now that exists. N-Lorem has done so much building. When I first applied with Nolan, it was actually Ionist, not pharmaceutical mainly. And now Stan Crook was CEO, and he started N-Lorem, and now N-Lorem has like their own labs and their own personnel, and they've changed so much and are developing and growing for the better. So this is something that's new. There is a pre-application submission inquiry form you may submit so that you know if it's worth going to a physician and going through all the elaborate application process. Next slide. The application process, it has to be submitted only through a research physician, and they have a new portal now that you submit it through too. There's very detailed instructions and guidance on their website. If you were interested, your physician and you would be provided with ample resources. Next slide. As I just said earlier, also newer development is if you are accepted, you do have to have your whole genome sequencing and your iPSC cells. If you do find an institution that has experience in research INDs, that institution more likely than not will be able to help you facilitate this. It is and can be a timely process, and sometimes the institutions may or may not fund this particular element, and that price can vary. So that is something to be aware of and a conversation to have in the beginning with your institution that is going to apply with you. Next, please. How long will it take? Well, as I told you, October 2020 is when we are accepted. And it is, what is this month? This is what, guys? July 26th. And we have not dosed yet. Anyone following our story, we are very close. As soon as I receive a more definitive date, I will share, but there's still a lot of moving parts. And every child and every institution has to have their own, IND and IRB. So the time depends very, very uniquely on that particular patient. Quick as possible, 18 months. Now the longer programs are 3 years. In our case, unfortunately, because Nolan was one of the first ever, but we're going on, 6 years. But like I said, typically the soonest is 18 months, and then within 2 to 3 years, usually treatment. Next, please. And here it is. Up there, see, 15 to 36 months. And it's just a little chart here to show you on how the process would evolve if you were to be accepted into the NLORM program. So talking about all this, you might be interested to hear, okay, like what are the clinical benefits seen? Well, like I said, and you know probably, and no one with KCNQ2, at least published or known to us, has received an ASO as treatment. So we don't know what the benefits can be specifically to our disease, but there is other diseases that have received the ASO, and NLORM has this on their website, their 2025 Colloquium slides. It is Dr. Lori Mignon's presentation. This is public. So she gave a great presentation if you want to look at it yourself, send me a DM, I'll send you the link, but it is public. So she explains a series of SCN2A patients that have received an ASO treatment. And she showed in her clinical trials, because even though it's one person, it's still a clinical trial. It's an N of 1. So Nolan will be a clinical trial, but he'll be the only participant. So anyway, what they have seen so far in neurological diseases treated with ASOs are reduction in seizures, able to reduce seizure meds, get off some of those medications, improved communication, improved mobility and motor control, independent walking achieved when someone was not independently walking, daily activities, were able to be more independent, improved bowel movements, which is a big deal for KCNQ2 kids, improved sensory processing. Some kids can now understand temperature better, and improved autistic symptoms, better interactions with the family and friends, which was, a significant increase to the quality of life. And some were able to gain independence, able to feed themselves and tie their own shoes, and these things they weren't able to do prior to their treatment. With all this being said, this doesn't come without its risk. I just had the meeting yesterday with the treating institution, and they have to tell you all the positives and the potential cons. And so I'm sure it's, again, this is published. There was 2 toddlers that were treated with an ASO with KCNT1 that fluid built up on their brains, and one unfortunately did pass away. One received a shunt and is still with us. NLORM works very hard to reduce adverse events, and in this particular instance, I get working very hard to make sure no fluid builds up in the brains. But until Nolan is treated, we will not know his particular response, positive and negative. So as his mom, I am obviously anxious, but I am excited because I hope once Nolan is treated, we can use this data and share it with our community, and then move forward and getting this treatment to more kids. And at this point in time, I can help anyone who's interested in applying to NLORM. You can reach out to me anytime. And if anyone has any questions, you can reach out to me anytime. That's about it, I think.
Thank you, Kara. I think Scotty's got a, I feel like I went off Nolan's picture too fast. So I'm just going to go here while Scotty drives us to the next part.
I was going to just say thanks, Kara. We appreciate you sharing your story, your journey, and offering to help fellow KCNQ2 families. So I think we'd like to spend some time. I know there were a lot of questions in the chat, and I think we're going to try to answer some of those live to make it a little easier to explain. So, Brooke, do you want to kind of go through, start at the top and work your way down?
Sure thing. Yeah. And apologies. I was trying to start typing answers when Kara reminded me I had to drive the slide. So my bad. But yeah, so I'll just try and go from the top. So first question, which is a question we get with some frequency in the community. So as some people might be aware, KCNQ2 mutations, they can be something called de novo, means it just happened in that patient. You check mom and dad, they don't have it. It's just, the luck or bad luck of the sort of the genetic lottery. In some cases, they can actually be inherited, and that's more often, if not exclusively, linked more towards the self-limiting neonatal epilepsy. But what some people experience is that while they had a mutation themselves, they had a certain experience with it where there was neonatal epilepsy, but maybe it resolved, that their child will inherit that deletion, maybe have similar symptoms initially, but that symptom development looks different from theirs. And so why that happens, I wish I had a really straightforward answer. Unfortunately, we don't know a lot about that. One of our scientific advisory board members, Sarah Wackusen, who's a professor in Belgium, she did something called a modifier study, which is essentially looking to see, are there other genes that interact with KCNQ2, whereas if you have a mutation, but have these certain set of modifiers, you have one disease progression, but if you have that same mutation and a different set of modifiers, maybe you have a different trajectory. So, that's, I think, our best guess right now, but it's not really fully understood. So sorry if that was a disappointing answer, but that's the best we've got right now. And again, please feel free to follow up with me afterwards. We can talk more about that. So then there's a question about deletions and ASOs. So yeah, really good question. ASOs don't seem like they would work well for a deletion, but actually, sorry if I'm making anyone motion sick by jumping through slides, but we did nope, we didn't. Thought we set ourselves up to answer some of these, but I'm realizing they're hidden. In the case of Dravet, it is a haploinsufficiency condition, and an ASO is used there in a way that can actually upregulate the working copy. And so, can I do this? Hold on one second. Unhide. And so, Can everyone see me as I'm like working through slides right now? All right, so we're just gonna, um, and then I'll go back to slideshow. So they can use this specific, and so this is actually a presentation that was for the summit last year, and I really promise eventually we'll get those videos up. But an ASO is in use for Dravet. It's from Stoke Therapeutics. They presented clinical data to us. There's a specific way this ASO works that can sort of change the productivity, so to speak, of the working copy, and in that way, it actually upregulates. So ASOs can work in this scenario of deletions, and they also have the advantage of not needing to be allele selective because you can put that same ASO on the non-working copy and it essentially has no consequence. So yeah, so this was not to say that it's not a viable approach for deletions. We just sort of focused today on ASO approaches for the dominant negative conditions, knowing that that often leads to more severe neurological symptoms. Okay. I just stay at the top, right? Are there ASOs aimed at more severe cases of KCNQ2? Yeah. So the allele selective mechanism that I talked about, these are meant for the more severe cases, the types of mutations that tend to lead to DEE. The tricky part about those, unlike what we're looking at here, where you can kind of just throw the ASO at everyone, these have to be allele selective, which is a really hard thing for genetic medicine to do. We're really good at just like going in and impacting a gene. We know how to find those, but to do one copy of the gene and not the other, that is still very, very tricky. And so that's where this allele selective mechanism comes in. This is the approach n-Lorem is taking with Nolan's ASO. This is also the approach Boston Children's Hospital is hoping to develop. And then if I kind of put my drug development hat on for a second, the reason that there's not more of these out there, in addition to it being tricky, it can be a very much personalized medicine because, again, you've got to find that marker on the mutated copy, but that marker might only work for a small subset of our rare disease, right? And so we've really got to be thoughtful about how, as these approaches prove to work, which we're all rooting for them to do for Nolan, how do we then transition that to say, hey, this is working. We've really got to make a pathway for this development to move forward. So there's work there, not only scientifically, but to kind of build some framework around making that happen faster and more efficiently. Hopefully I'm answering these, the sort of the foundation of the question and not just rambling on, but feel free to send follow-ups. So understanding, that intervening earlier would be ideal. Right, so this is a great question. Is there an age that's too late? I say no. I'm a big genetic medicine proponent personally. I was working at a company called Encoded previously. They have a product for Dravet. They are targeting very young children and seeing promising results, but I don't think there's no change that would occur for older children, and they certainly want to eventually do that. Again, as Kara mentioned, Nolan is going to be an amazing leader here, and we're going to learn and see. And then hopefully as we, learn its potential, learn its safety, set up framework for development, yes, we'd love to get it to kids as early as possible. But I don't think with ASOs, there's a reason to believe there's a hard ceiling. Okay. Just churning through. Someone stop me if I'm, talking too much or something. How can I find out if my son's variant is gain of function or loss of function? Fantastic question. This is really challenging. And yeah, Kara, if you want to jump in anytime, let me know. But
I was just gonna say real quick with the age thing. I went out last October, brought my family to the n-Lorem conference out in Boston, and they presented a lot, and it was great information. And one of the things I took away from there is they were treating some teenagers and seeing results. So, and this idea that, of course, younger is probably more likely than not better, but the idea that if there's a certain age hits, there's no hope. It just doesn't exist. We don't know. Our kids are going to be the first ones doing this, so they don't know. We don't know. So don't give up hope.
Thank you for that. Where was I? Did we move a question off?
Yeah,
You
sorry,
were
Brooke, and
speaking
this
to
is
gain and loss
something.
of function.
Yes, how do we know that? Yeah. So this functional characterization piece, as I hope is now appreciated, right, is really important to understand when it comes to therapeutic development. And yet it is not something that is straightforward to learn about. So we are trying, as KCNQ2 Cure Alliance, as a foundation, we're trying to, kind of tackle that in different ways. One way is just, Michelle's developing a spreadsheet with the published literature when, if it's been characterized, what that literature has said. And to dig down to like what it means to be characterized, it's a very academic process right now where they create the mutation in a certain cell type and then they do electrophysiology recordings of what that cell does when it has that mutation. So if that cell has that mutation, does it look like it's shutting down the potassium flow, or does it look like the potassium flows, increased? If it looks like it's shutting down the potassium flow, that would be loss of function. If that potassium flow is measured as increasing, it's a gain of function. And so it is not a clinical characterization at this point. There is a lot of conversation around other disorders that impact channels in the brain as to how we can make this more structured. So for now, I'd say look for some of our resources, ask us. And again, if you have a variant that, that is shared and has been characterized like that, that answer should be the same across that variant. So yeah, so stay tuned for more resources on that. But unfortunately, there's not one clear resource or not one clear place to go, and not all variants have been characterized.
And I just want to chime in and say that it's also important to know that the overwhelming majority of KCNQ2 variants are loss of function. So know that going in. And there is a little bit of kind of a phenotype that they describe with gain of function, but it's not always set in stone. And we can certainly share resources where they kind of give a definition explaining kind of what they feel the presentation is for a gain of function.
Yeah, great point, Scotty. Okay, so right, so if my daughter's variant is a missense variant, how does that impact the viability of ASOs for her? So what I would say there is that likely that missense variant, it could be viable for one of these allele specific strategies that we're talking about. So if that missense is leading to that dominant negative loss of function or a gain of function scenario, you could go in and turn off that copy of the gene that's making that protein that you don't want made. And so again, missense most often leads to some sort of protein being made that's either not working as well or working in a way it's not meant to be. And so in that case, allele selective would be appropriate. If your missense actually turns it into a case where you've just lost that protein, this allele selective approach, it might not, it wouldn't be the right strategy because that copy of the gene is already missing. So I think again, sort of that knowledge of the functional characterization would be helpful to understand if it would be the appropriate approach. Okay. Next question is about a trial. So if there is, if there is a trial, how do we know about it? So right now with ASOs, essentially Nolan's N of 1 is the absolute closest we are to dosing a patient. And what we don't know right now is if Nolan's ASO, because it was built to find a marker that is special to Nolan's copy of the KCNQ2 gene that has the mutation, we don't know if that marker exists in anyone else in the community, right? So right now we can't say that, yes, if this works for Nolan, we're going to start signing everyone up and give them this ASO because we just don't know if it'll work for anyone else. What we are trying to do, and that's part of the goal of this, we want you to be aware of NLorem. If you can, walk through the steps and get enrolled with them, they will do something called long read sequencing, which is something that came up in the Boston Children's webinar, where they're going to go through and essentially look very carefully at your KCNQ2 gene to see if you would be kind of a match to Nolan's ASO, in which case, they could then, we could think about what that N of 2 trial would look like and have another person enrolled. But the NLorem strategy right now is very much one individual at a time. Boston Children's, again, is working to try and find a marker that can have a few people right off the bat. They are not quite ready yet for clinical trials. As soon as they are, we're all going to be the first to know, and we're going to find the right people that fit that ASO to be part of that. And sort of the one bridging step, which, we just want the community to be aware of right now, is that that long read sequencing piece is how we're going to know who's appropriate for which therapies. And so when the time is right and we understand how to communicate all this information, we can think about how to get that information for those of you interested in ASOs and what researchers to work with. So that's something that will be forthcoming as we start to understand where these therapies are in development. Okay. We are 2 minutes away. All right, I will get through what I can. I'll try and talk faster and then we can follow up later. There's a question about not seizures, but EEG abnormalities. Yeah, great point. And again, right now, we don't know what these ASOs can do. We would hope that they can, kind of normalize some of the EEG signals. I'm guessing that's going to be a feature of Nolan's assessment. I know, on other clinical plans for like N of 1 trials, EEGs is part of it. So we might learn more as we go, but I don't think we know right now. Kara, anything else on that? Is Nolan having EEGs along the way?
Yes, it is one of our endpoints. It's not one of our primary, but it's a secondary.
Great. All right. And then Scotty answered about our Biohaven versus the ASO. Okay. Are there trials for kids outside the USA? Yeah. It's a good question. And Kara, you said NLorem is US specific right now, correct?
Right. Oh, sorry, hang on. Wait. Right now, yes, to my knowledge, they are US specific. I do know that they are having meetings and collaborations with certain institutions abroad, specifically Canada. I personally know, but if you go on their website, and if the official answer at this point in time is within the States.
Yeah. And, we'll talk more with Boston Children's to understand what that will look like. But then also, just because since the Biohaven drug came up, compassionate use and other trials for these anti-seizure meds, like that, there is some potential ability to get treated outside the US. So if you have questions about that, please feel free to email us specifically. And if everyone can stay for like 1 more minute, I'll try the last 2. So this question comes up a lot. What are the chances my next child will be impacted? If it is a de novo mutation, as you're describing, mom and dad got tested, neither of them have mutations in their KCNQ2 gene, it is highly, 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 highly unlikely that you would have a child with a KCNQ2 mutation. But, I would encourage people to reach out to genetic counselors. And then, yes, can you contact someone to see if my variant has been characterized? For now, email me, brooke.babineau, kcnq2.org, and we'll get some resources out soon. Yeah, do we do it?
You did it. You did it. And you can reach out to me as well if you are unable to find Brooke's email, and I can connect you. Um, just want to say thanks everybody for joining. I think this was sounds like a very important topic that our community wanted to hear. And we have this part one that we've completed today, but we'll be doing a part two that'll follow up more on gene therapy approaches. So you will have to register for that as well. Marissa will be sending some information out about that shortly. Um, before you go, if you have a chance, Marissa is going to put a link in the chat to do an evaluation on the webinar. It just takes a minute. This helps us determine what our community really wants to hear and help us pick topics that align more with what the community wants versus just maybe what one or two of us think is important. And you can always find these webinars listed on our YouTube channel if you have any, questions or want to go back and revisit things. And as always, you can reach out to any of us, whether it's through Facebook or email, to ask questions. And if we don't know an answer to something, then we can certainly put you in contact with the person who can at least try to do a better job of answering. All right, we appreciate everyone's time tonight and hope you have a good evening. Thanks.